Welcome to Face Values, the podcast where we peel back the layers of cosmetic surgery and skincare to help you understand how your skin is aging and what you can do about it. I'm Dr. David Jack. I'm a cosmetic doctor and skincare brand founder. I'm based in London. I've got clinics in London and Edinburgh. I've got a real interest in just understanding more about how the skin ages. So I'm going to be joined by lots of guests who are real experts in the field. So I hope you enjoy and keep tuning in. If you're struggling with pigmentation, then you might want to check out my new yellow peel, which has just been launched with a new formulation. It's taken about 3 years to reformulate, and it contains a blend of ingredients that will help to tackle any form of pigmentation, whether it be melasma, sun damage, or post-inflammatory hyperpigmentation. If you want to check this out, it's on my website, drdavidjack.com, and it is available now. On today's episode, I'm joined by Dr. Mary Sommerlad, who is a consultant dermatologist. She has a practice between the NHS and also the private sector, and she sees children and adults. So Mary, tonight I wanted to talk to you about hyperpigmentation, which is a topic that comes up all the time in my clinic, and I believe that it's something that you see a lot of as well.
Yeah, absolutely.
So tell me, what would you say your approach to hyperpigmentation is? When somebody comes in, maybe with some sun damage, what would you be looking for?
Well, first of all, thank you very much for having me.
A pleasure.
Hyperpigmentation is one of my favourite conditions to treat because it can be very well managed, but it can also be very badly managed. And the first thing I look for when someone comes in saying they've got some dark marks is... what's the diagnosis? So I need the history. The history is really key. When did the dark marks start? What's their lifestyle like? Their hobbies? Are they a sunbather? Where do they grow up? What do they do for work? Do they have a pet? Someone they walk outside like a dog? What's their skincare routine? What kind of products are they using? Are they using harsh products? Any physical exfoliation? So I ask and ask and ask. And sometimes patients will look at me thinking, why are you asking about whether I use a scrub on my face? And I'm thinking, super important. So a really long history and then the examination. And the examination is really important because although there can be many different reasons why you can have dark marks on the face or the body, usually there's always a telltale sign of what the diagnosis actually is. Once you have the diagnosis, you can plan treatment. Without a diagnosis of your dark marks, you can't plan the treatment effectively.
Yeah, so most commonly, what would you say you're seeing in clinic? Would it be sort of sun damage related pigmentation or, Yeah.
So I would be splitting patient groups just for the purpose of our chat today. If you have... I would say white European skin and dark marks. Often this is sun-induced. Not always, but often sun-induced. So this is from sunbathing. This could be an inadvertent sun exposure through hobbies like gardening, dog walking, having lived abroad, just repeated exposure to sun over a period of time. And those freckles that maybe started off in childhood and teenage years can then develop more into larger brown patches. We call those solar or actinic lentigos, but globally they are just photo damage or sun damage. Then if you have darker skin types, so skin of colour, brown and black skin tones, your natural pigmentation, your melanin, protect from sun damage, but you're still extremely prone to hyperpigmentation. And often this can be because of what we call post-inflammatory hyperpigmentation. So maybe you've had some acne, some eczema, psoriasis, any number of inflammatory processes on the skin or traumatic processes. So damage to the skin breaking for any reason, including surgery, that leaves you with a dark mark that either takes a long time, several months to fade, or sometimes never fades at all. So sun damage, if you have lightly pigmented skin, post-inflammatory hyperpigmentation in darker pigmented skin, and then there's a condition called melasma, which straddles all skin types, much more common in women, kind of 9-to-1 female to male. And this is a combination of female hormones and sun exposure and probably genetics and environment thrown in there. But those are, like, broadly speaking, the reasons why I see pigmentation in clinic. And the reason why the diagnosis is important is if I'm treating someone who has post-inflammatory hyperpigmentation, the treatment will be very different to someone who's got photo or sun-induced hyperpigmentation.
Yeah, and often some can coexist as well, I guess.
Absolutely. Yeah. People always laugh that dermatologists are always talking about sun protection.
Sure.
Be that sunscreen or wearing a hat or definitely never sunbathing.
Yeah.
And that's because sun damage not only can prematurely age the skin, but part of premature aging is pigmentation issues.
Yeah.
And you can have melasma or post-inflammatory hyperpigmentation and sun damage. And actually a lot of research now points towards melasma being part of a sun damage condition. So it's a bit inflammatory, but also it's part of sun damage.
Yeah. And differentiating between them, what is actually going on at a deeper level in the skin? And obviously sun damage, there's damage to the cells that are producing pigment, the melanocytes. But in melasma and in post-inflammatory hyperpigmentation, what is going on that is different in terms of the actual cellular changes?
So if I have a patient with melasma and I took a little skin biopsy and I looked at it under the microscope, what you see in melasma is actually changes at what we call the dermoepidermal junction. This is just a phrase we use to describe the kind of border between the very top layer of our skin, which we call the skin barrier or the epidermis, and then that deeper layer of our skin, the dermis. The dermis is the part of our skin that makes our skin look plump. It's packed full of collagen. It's when we use certain skin products, we're trying to boost that collagen. That's all kind of dermis, whereas epidermis is the texture of the skin, the way it feels. In melasma, at that little junction, that's where our pigment cells live. And there's a lot of disorder in melasma. So if I look at that skin cell under the microscope, what I'll see is instead of seeing what should be beautiful rows of skin cells, it's all a little bit higgledy-piggledy. And where the pigment from pigment cells, which we call melanocytes, where that melanin is sitting, is instead of just sitting in a really lovely little border, it's dropping into the dermis where we shouldn't be seeing pigmentation. But it's also extending upwards into the epidermis where it could be. Definitely you see more melanin in the epidermis in people with skin of colour and black skin, but it's kind of densely packed there. There's more of it than you would expect. Also, the blood vessels look weird in melasma. So you see vascular changes and you see pigment changes and you see skin cells themselves changing as well. We call those skin cells keratinocytes. In post-inflammatory hyperpigmentation, this is a different process to melasma. I'll use maybe the example of, say, acne. So maybe if I take a biopsy from someone with post-inflammatory hyperpigmentation from their acne, I may or may not see some scarring, so scar tissue present. I might see some signs of active acne in that microscope area. So I might see if there's a little hair follicle there, maybe that hair follicle looks a bit plugged. I'll see lots of pigment, but the pigment might actually just be sitting in the epidermis. And that's that top layer. It may not necessarily be in the deeper levels, although in some people, again, especially if they've had a lot of inflammation causing their acne, you might see pigment dropping into the dermis layers. So the pigment that you see in post-inflammatory hyperpigmentation will be around where that skin problem is. In an area of melasma, we're talking about large areas of skin rather than focal areas.
And that's largely related to kind of hormonal things. So in terms of treating these things, obviously you'll have a different approach depending on the type of pigmentation or the primary type that is there in the skin. With melasma in particular, because I know that's something that a lot of people struggle with, particularly I see a lot of female patients in my clinic, and I'm sure you do as well, more so than men. What would be your approach initially, obviously depending on skin type and things? How would you approach treatment of melasma?
So with melasma, first of all, you want to definitely have a good relationship with your patient. Because melasma is a chronic condition. It's really important people understand that at present there isn't a cure that makes it go away forever and never come back. So it's a condition that we're managing, but it can be managed well. you need to tread carefully.
Yeah.
Because when you're treating melasma, first of all, you want to correct those changes we were seeing at that kind of junction between the top layer of skin and the dermis. We also want to get rid of pre-existing pigmentation. So it's kind of a two-pronged approach. We also want to make sure we don't induce more pigmentation. And I'll kind of touch on that more towards the end of the little sentence I'm going to say. So first of all, sunscreen. And it's got to be tinted.
Yep.
Why does it need to be tinted? It's got to be tinted because we know a lot of melasma is driven by visible light. So yes, hormones, and we think a lot of female hormones, estrogen, progesterone. We know some women get melasma for the first time in pregnancy, but you can also get it having never been pregnant. You can also get it from using contraceptives, and also we know men can get melasma, but significantly to a lower degree than women. The visible light needs to be blocked. Traditional sunscreens don't block visible light. Because at the moment, the best studied filter for visible light is iron oxide. And that gives a kind of reddish tint to your sunscreen, which is why people often tint them in order to make it more cosmetically acceptable. So using your tinted sunscreen all the time. Why? Even in the winter, it's because visible light can come through glass. It's the light we see that makes the difference between day and night, rather than your, say, UVB light that we see more of in the summer months. You need to make sure that it's being applied and reapplied. And the great thing is there's lots of fantastic sunscreens now. I love a sunscreen that also has a bit of an antioxidant. Skincare, super important. So we'll start off with things people can do at home. Skincare in the mornings. I love using antioxidants because they work really well with your sunscreen synergistically. And if they're added to your sunscreen, perfect. You want to make sure you're not using any skincare that's irritating your skin. Why? Irritation will drive melanin production, make darker marks darker. I love a retinoid in the evening. Why? Retinoids are fantastic for turning over skin cells and helping lose some of that excess pigmentation that we want to get rid of. I traditionally don't like liquid exfoliators so much, but in melasma and hyperpigmentation, gentle liquid exfoliators that aren't going to leave you feeling really irritated have a great place in, again, helping turn over skin cells or just gently exfoliate. But I want them to be liquid rather than scrubs. And then in clinic, my approach is very cautious, conservative first. So are you using your sunscreen? Have we got you on the right skincare? Are you able to adhere to that? With melasma, if you read the textbooks, there are like 100 different ways to crack the nut. And I think anytime you're seeing huge lists of potential options, it's because nobody knows what the ideal thing is. I think increasingly we know that there's a traditional approach of a triple combination cream, which can use hydroquinone. Hydroquinone gets a really bad rap because it can be used as a skin bleaching agent, but used correctly and with other ingredients, it can be very helpful and quite a conservative approach to managing melasma. We increasingly know that tranexamic acid, oral tranexamic acid, is phenomenal for melasma and post-inflammatory hyperpigmentation as well. This is taken orally, so I use it orally. It can be used topically.
It can be injected.
It can be used as part of microneedling. But the evidence based around using it orally is growing all the time. And using it in combination with topical treatments. Very safe drug, provided you don't have any risk factors. And it's important that you, if you're thinking of oral tranexamic acid, you see someone who can take a careful history because it was designed to stop bleeding in surgery, which is amazing. And menorrhagia. Amazing. It's an essential drug in the WHO for any country in the world should have this. But the way we use it for melasma, which is long-term rather than short-term for surgery or for the 5 or 7 days someone might be having their period, it's a longer-term thing. So we need to make sure we're not increasing the risk of blood clots. So we need to take a history of stroke, clots, recurrent miscarriage, etc. So that's how I love to start treating melasma. A block of time with oral treatments, prescribed topical treatments, and then time off those treatments as well, where we're focusing on sunscreen and topical skincare. But then how about removing that excess pigmentation? And this is where you'll see lots of different options. I think in going from least scary invasive to quite invasive, high risk.
Yes.
Again, it depends on your skin type as well. How reactive your melanocytes are, how much of a risk you're going to have from post-inflammatory hyperpigmentation. So I like to think least invasive thing to do in a clinic would either be a very gentle peel, but you need to make sure, for me, if I'm going to do a peel for a patient, I have to make sure they're going to stick with the pre and post procedure skincare meticulously.
Totally.
And that includes things like the skincare, the sun protection, but also being careful around you're not about to go on a very sunny holiday because we want to keep the pigment cells really quiet. Microneedling is great. So it could be called microneedling, or some people just call it needling. What this does is it helps, you get little punctures in the skin that help boost collagen, but it's also very regenerative to the skin. Done in the right hands, it can help rid the skin of excess pigmentation. You might need a course of treatment. It's low heat though. Which, why do we care about low heat? It's all about waking up pigment cells. If we wake pigment cells too much, we can drive pigmentation, hyperpigmentation, which we don't want for melasma. Then you can have more aggressive peels. Big risk of an aggressive peel is if you have skin of colour, you might drive post-inflammatory hyperpigmentation. So you might have what looks like a fantastic result initially, and then very quickly things spiral and you see darkness. Lasers, I love a laser for melasma in the right patient, the right setting, the right time of year. And it's got to be understood that we can't put too much heat in, that they may need repeated treatments, that there's a high risk of pigmentation being made worse. And how do they feel about that? We'll always try and improve it, but that is always something that we consent people for. If you have more lightly pigmented skin, then all of those treatments, whether it's peel, needling, using a laser or an energy-based device, can be helpful. And you are slightly at lower risk of getting a lot of post-inflammatory hyperpigmentation, but you still might hyperpigment. So still really important to have that conversation. And my approach always to every patient is go cautious, go slow, and what are you trying to achieve? Because the when you kind of go in all guns blazing, sometimes you're left with 6 months, a year of trying to undo some of the procedure damage, which I don't want for my patient, and most people don't want.
Absolutely.
So we have to think about the end result. And less, in my opinion, is always more with melasma.
And how do you navigate that with patients, though? If you're saying that you'll see a gradual change over, say, a year or something, how would you go about? Because patients are often quite impatient with that. How do you go about managing those expectations? Is it just a case of being very upfront? Or?
It's absolutely. So as we discussed at the beginning, that relationship with the patient has to trust that I have their best interests and that I am using evidence-based practice and my capacity as a consultant dermatologist to give them the safest result. Also the most effective result, but effectivity can take I prefer it being a gentle, slow approach rather than taking the gamble of, if we laser you today, you might be okay, but you might not. It's difficult to know. If someone feels like they want very aggressive treatments straight away, then I'm probably not the right doctor for them. Because I think we've probably both seen people who come saying, I had this done. Had I known this is what would happen to my pigmentation, I would never have done it. Can you help me? And, we go very slowly and The good thing with pigmentation, I'm always super hopeful. Like, I hope I'm not coming across as too negative. There's so much you can do and really manage things without people feeling like, gosh, I always have to wear full coverage foundation. Gosh, I'm always thinking about pigmentation. But it's definitely a journey.
Yeah.
It's not a quick fix.
No.
It can take a while. I always say, it's a couple of summers of you getting really used to being really careful around certain things. And that includes things like the sauna, the jacuzzi, the dog walk, all of those things that we sometimes don't think of for our skin. But it's really important for something like melasma.
Yeah, absolutely. And in terms of lasers, you touched on that for melasma. What type? Obviously there are certain lasers which are very high energy, which you just wouldn't use. What type of lasers do you like for treating melasma?
So the nice thing, but also the downfall of lasers for melasma is there are so many different ones, and the one that you've trained on is usually the one that you will say it's the best one. It's the one I use all the time. Yeah. So I'm really familiar with using an erbium YAG laser profractionally.
Sure.
So and when I say profraction, that means that when I'm treating the skin, we're not removing everything. We're removing things in kind of little bite-sized bits, making little microchannels into the skin that help not just regenerate collagen, but also remove pigmentation. I use lower heats. The darker the skin type, the fewer the passes.
Sure.
So then we're planning more sessions rather than lots of heat or several passes.
Yes.
So people need to also understand that the laser's not just one and done. It might be 3 or 4. You might need to repeat it again after the summer, and maybe as you go into the autumn months, and that might just be a maintenance thing. Yeah. There are other lasers though. So pico lasers, traditionally people have used a lot for pigmentation. ND-YAG lasers, fantastic. But again, it's not necessarily the laser per se, it's also the operator for sure, and the pre and the post.
Sure.
Because you could do the most beautiful, have the most wonderful laser session, but if someone's about to step on that plane to the Mediterranean and have 3 weeks in the sun, that's going to impact on the result. Yeah. So it's operator dependent, patient dependent, and pre and post as well. Pre and post procedure dependent.
Sure. And do you tend to, particularly in darker skin, do you tend to pre-treat with?
Yeah, absolutely. Yeah. So in darker skin, and to be honest, even lighter skin tones
with melasma.
I will want to pre-treat. Usually with topical treatments. Tranexamic acid orally beforehand is amazing as well, because we're settling everything down. We're reducing our generation of pigmentation, but also vascularity as well, which is a part of melasma. And I will always ask people, because sometimes you could look at someone and think, I think they have very lightly pigmented skin, light brown eyes. Maybe they're a lower skin, we call it Fitzpatrick type. It's not ideal, but basically Fitzpatrick type is, Dr. Fitzpatrick was a dermatologist. He typed people's skin based on how they respond to UVB light for phototherapy, which is a treatment for skin disorders. And he's used the classification 1 to 6, and he said type 1 is if you have red hair, blue eyes, and you never burn. You always burn, you never tan. And type 6 would be you have black skin, brown eyes, and this word never burns, but we know people with black skin can definitely burn. And then all the skin shades in between. The reason it's not great for pigmentation is you could look at someone who has maybe to you very like white skin, brown eyes, but maybe they have mixed heritage and they go in the sun and they tan and they go super olive or brown within a day and a half. If I put a laser on that person, they are going to get post-inflammatory hyperpigmentation and it's going to last a while. So I always want to ask the person as well, what are you like in the sun? When you go on holiday, do you brown very quickly? And actually, I find sometimes people with olive to brown skin types are the most unpredictable and difficult to treat. Because if you've got black skin, great, I've got an idea that you're going to hyperpigmentate. I'll throw my hydroquinone. If you have red hair, freckled, I'll still ask the question of what happens when you go in the sun. But I have that lower fear,
Yeah.
but people in between, you have to ask, what do you like? Some people say also look at the markings on the hands to see how pigmented they are. Also ask about parents. What do their parents look like when they go in the sun? Those sorts of tips. Yeah. But I definitely would pre-treat, and I like to post-treat as well. Once the skin has fully healed, I will like to continue on with either a triple combination cream, oral tranexamic acid as well. Yeah. And you'll hear me say oral tranexamic acid all the time. It's not licensed for melasma. Yeah. So I should get that across. It is used off license. But there's a huge wealth of research out there now. And I think in a medically qualified person who's able to ask about the risk factors and properly counsel the patient on how to use it, when to stop. You know, you don't use it non-stop forever. It can be very, very effective.
Yeah, absolutely. That's great. That's great, mate. And what about, so just kind of barn door, sun damage in childhood, obviously lower risk of things like post-inflammatory hyperpigmentation in lighter skin types. Lasers are often a kind of first line things. Definitely people coming into my clinic. Is that something that you see a lot of as well? And what would you be the type of lasers that you'd maybe think of for sun damage and with not really melasma type skin?
So pure sun damage, I love IPL or BBL.
Yeah.
So these are kind of more light than a laser.
Yes.
They have an amazing ability, especially, big thing, if you have black skin, I would even say brown skin, I'm quite cautious with light, you can't have IPL or BBL. Exactly. But also the risk of you having significant photo damage, like freckling, is a bit reduced. Sure. So we can park that to one side. Really important though, with IPL, is being aware that you might need repeated treatments, especially if it's the first time. So the classic would be maybe someone in their 40s, they've noticed they're getting lots of brown patches, diagnosed them with photo damage. Maybe they've got premature lines and wrinkles as well. And they just want to look, usually people say, I just want to look fresher. I want my skin to look more youthful. Maybe they're thinking, maybe they've got a big event coming up. So I'll normally say sessions, probably about 4 to 6 of IPL or BBL, are very similar treatments. Sun protection, super key, really important. We talk about downtimes a lot in any type of energy-based device. With different IPLs, or if you're using BBL, there usually is a period of downtime where you'll need to be a bit careful about going out in the sun, using sunscreen quite meticulously. Sometimes people will notice that they get what looks a bit like scabbing of those freckles coming away, usually within the first kind of week of having treatment. And then the skin, that kind of scabbing or even darkening of the freckles kind of fades, and you're left with lighter brown marks. The more treatments you have, the lighter those sun-induced kind of freckles, or we call them lentigos, will appear. For some people, they might need repeated sessions after every sunny period after, so they get to September, October, and I'd recommend maybe 2 or 3. For other people, actually, they're really meticulous afterwards. Especially if you don't have that outdoor lifestyle and you're starting using sunscreen, etc. So I guess be really hopeful. Skincare, super important as well. So I always say to people, if we're getting rid of your sun damage, you need to think about your skincare. In the morning, that's using your antioxidants, that's using your sunscreen, especially if it's photo damage. Every day, sunscreen. A lot of people ask, do I really have to? But especially someone who's got lots of freckling, you have an increased risk of skin cancer. And not to frighten everyone, you've got to be, but it is really important. We know skin cancer rates are rising. And a risk factor is being heavily freckled, repeated sunburns, especially childhood sunburns and sun damage. So being just aware of protecting your sun, your skin from the sun, and then your nighttime skincare routine, making sure it's helping restore the skin, but also you're using ingredients that focus on fading away dark marks, that are reducing inflammation as well, a bit soothing as well. With using things like IPL and BBL, there's interesting literature showing that they can reduce signs of pre-malignant skin changes. So these are things like actinic keratoses or solar keratoses. So they can be really beneficial, not just from a cosmetic look, but also reducing those little...
So they're actually destroying some of the early cells.
Absolutely. So it's if anyone's thinking, I'm heavily sun damaged, but will I cause my... Because a question people sometimes ask is, if I have... laser or light treatment, will I get skin cancer or damage my skin? Because we sometimes think of sunbeds as energy, etc. And reassuringly, no, they can actually be supportive.
Yeah, that's really interesting. Cool, Mary. Well, thank you very much for that. If people want to get in touch with you or visit you in clinic, how do they do that? What's the best way?
The best way is probably going onto my website. Or emailing hello@drmarysommerlad.com. And you'll be directed, whether you are an adult over 18 or under 18, where else are you in the paediatric clinic.
Great, thank you. Thanks very much, Mary. So that was Dr. Mary Sommerlad. She is a consultant dermatologist and treats children and adults in her clinic. If you enjoyed this episode, don't forget to subscribe to the podcast. You can also join me. I do live masterclasses once a month, which are free to join. You can join via my website, which is drdavidjack.com, and I hope to see you in the next episode.